This is a patient who has hypertension, systemic arteriopathy. The clinical history was the beginning of May, dyspepsia, anorexia. He was admitted to neurology department for ataxia, underwent angio-CT, and look at the creatinine. He got a significant increase in serum creatinine until he required actually dialysis, and he was then slowly recovering. No other reason for AKI except he received a significant amount of contrast. So I think that we need to tell people that the problem exists. There are radiologists around the world that say that this is not a problem. Well, there are several aspects related to the possibility to prevent this. And tomorrow, Paul Palevsky is going to speak specifically about the PRESERVE trial, so I do not anticipate this. But I want to mention that the cardiologists, on the contrary, have discussed this, and they found that this is important because they found that their patients actually are staying longer in the department, they have worse outcome, so they want to have more patients on the cath lab, and this is disturbing, right? So the cardiologists hate the contrast-induced AKI. But the question is, radiologists sometimes say this doesn't exist. How can you see something if you don't look for it? They never see the patient again after the CT. How can you prevent if you don't know it? And how can you discuss incidence if you don't measure it? I think that the whole target for us, nephrologists and intensive care physicians, is just to increase the awareness and alertness about the possibility of AKI after contrast imaging techniques. Maybe it's just an association, maybe it's a causative effect. But we know that the increasing incidence of AKI due to comorbidity, due to the aging of the kidney and the patient, certainly finds in iatrogenic complication one of the main causes. Contrast media use is increasing because we have an expanding use of intervention requiring contrast medium. We have new indication like the TAVI and other interventional oncology practice that Dr. Luca will present, and the aging of population. Interventional cardiology is a growing field. They are expanding actually the number of procedures and the complexity of procedure that they do. And also in oncology, we have a really growing field where repeated contrast imaging techniques are requested. Now, it seems that a substantial proportion of patients receiving contrast media are at risk of CAKI. 1 to 7% patient overall. We recently did a study in our hospital, patient not at risk, 4%. So it's not negligible. And when you go up with the risk of chronic kidney disease, then you may actually overcome the 50%. The reported incidence is a problem because it depends on the population that you study, and also it depends very much on the terminology you use to define AKI. We are now used to use the 0.3 milligram per deciliter according to KDIGO criteria, and whether you use rifle, you use Akin, or you use KDIGO, you immediately see in the definition somehow affects frequency of AKI, because if you wait until creatinine double, then the incidence is very low. But if you look for 0.3 milligram per deciliter, then this may be a very important issue. And of course, there are factors affecting the situation that may alter creatinine generation and removal. So creatinine is not a very nice indicator. And for this reason, we are actually using biomarkers. And we have created the kind of continuum of AKI that goes indeed from what John Kellogg calls the kidney stress to the situation of real damage, and finally dysfunction, and different aspects can actually be moving from one condition to another according to the presence of positive or negative biomarker and positive or negative creatinine. A study we're doing now, for example, is the one on subclinical toxicity of contrast media. If you have patients that receive different contrast media and they have no rise in serum creatinine, you may say this is safe. But what happens if one of the two contrasts rise biomarkers, even in presence of a normal serum creatinine? Can you still say that this is safe? At least we may say that the kidney is under stress. Now, looking at the pathophysiology, we know that we may have direct toxicity or hypoxia, or we have also the problem of ischemia that affects this. But we certainly know that mortality and hospital length of stay are worse in patients that develop contrast-induced AKI, and the long-term cost of this patient increase. Again, the radiologist doesn't see this. The vascular surgeon probably doesn't see him. And when the vascular surgeon wants to do another angio-CT, I always ask, do you really need it? Do you really need it? What do you do if it is positive? What do you do if it is negative? Tell me, because I am going to see this patient with problem in the long term. And even a transient increase in serum creatinine is a sign that there is a kind of chronic kidney disease underlying, there is a high susceptibility of the kidney. That kidney is not normal. It is a doorway to chronic kidney disease. You have higher risk to develop chronic kidney disease or even end-stage kidney disease. And this is especially true if you have an elderly patient. Look at the numbers that go up when you are actually older. For the risk factors, we have modifiable and non-modifiable risk factors, but we need to be aware. And there are several scores today that tell us, like the Meran score, how much the patient is at risk. Because it is not just a matter of how much or what type of contrast you give, but also how susceptible is the kidney. Now, the PRESERVE trial is going to be commented tomorrow, but there is a nice commentary by Richard Salomon on the trial that basically say that preventive measures have been failing over the years, not showing specific advantage, except the fact that hydration may be important, but again, some papers have shown that hydration may not be the final answer. We wrote a little editorial saying that hydration may be the answer if you really achieve hydration. How can you compare two people who one started very dehydrated, the other starting overhydrated, and you give the same amount of fluid? They cannot have the same effect. So volume status affect the risk of contrast-induced AKI, and only if you are, let's say, euvolemic and you achieve a little bit of overhydration, you are probably protected. There is a kind of U-shaped curve. If the patient is dehydrated, or if the patient is overhydrated in case of heart disease and congestion, you can have the compensation and develop AKI based not only on the administration of contrast. And in fact, we have seen using bioimpedance that only those patients who achieve a correct level of overhydration after fluid infusion are protected from the risk to develop AKI. The volume is important. If you deliver less volume of contrast, you deliver less toxic to the kidney. And the type, you may say there is some conflicting evidence. Well, there is no question that from the pathophysiological point of view and from some trials that have been presented, especially for intraarterial injection, non-ionic dimeric isoosmolar contrast media are probably less toxic compared to other. Toxicity increase with osmolarity, and this has been demonstrated in different conditions. Also, the effect on circulating cells and endothelium has been demonstrated based on different osmolarity. Also, the effect on vasoconstriction in the animal has been shown compared to low osmolarity contrast media. I just remind you that the low osmolarity contrast media are not really low osmolarity. They have a lower osmolarity than the higher osmolarity, but they are still high osmolarity compared to isosmolar. And as I mentioned before, there is this meta-analysis done by McCulloch showing that especially when you deliver in intraarterial and a certain significant amount of contrast, the use of udixanol compared to other contrast media seems to benefit. The same is true for the recommendation by KDIGO guidelines that recommend to avoid high or smaller contrast media and possibly to use iso or low osmolar contrast. In cancer patient, the injection of contrast media represent one of the most important risk factors, and for this reason I want to give immediately the word to Professor De Luca that will continue my talk based on oncological patient. For the moment, I thank you very much, and please, Dr. De Luca, go ahead.